All right. Well, hey, everyone. I just was excited to do this journal club, and I really liked this article, and I invited Dr. Vickrey to be with us too. So hopefully it'll be good. I think this article came out in 2023, so it's a pretty new article. And, you know, I don't know if everybody on the meeting today does dialysis and uses this crit line. So I thought to start, I will just tell you guys a little bit about the crit line, and then we'll get into the study. These are the two monitors that were used in the study, the crit line 3 and the crit line 4. And they're monitors that we use to monitor patients that are having hemodialysis, and specifically when we're doing ultrafiltration, it's a very useful tool to have. And the reason we need to do ultrafiltration for animals that we're doing hemodialysis on is a lot of them unfortunately present in this state of volume overload that ends up being life-threatening. It can occur for various causes, but certainly acute kidney injury and ureteral obstruction are ones that we see frequently. But critical illness is significantly associated with the risk of fluid overload. And by that, I mean renal disease, acute lung injury, sepsis, even major surgical procedures. And, obviously, it's a condition where more fluid is entering the body than is leaving. And it's definitely known to increase morbidity and mortality in our patients and humans. So we can use ultrafiltration, which is a extracorporeal technique when you're on the dialysis machine, where you can pull or push water through the semi-permeable membrane and remove some of that extra fluid that is on board. This could be performed either while you're doing hemodialysis or as a separate modality known as scuff. But water molecules, they're small. They're about 18 Daltons, and they easily fit through the pores of the semi-permeable membrane. And that rate at which the water can be moved through the membrane is determined by the machine, partially by the transmembrane pressure that's created by the machine. And also, each dialyzer has a permeability to water that's represented by its KUF. And, some dialyzers have low KUF and have low permeability to water, and others have higher KUFs and have higher permeability to water. When you're doing ultrafiltration, you're pulling fluid from the vascular space, and that's leaving and going in a waste bag. But sometimes if you do that too rapidly, you can create a situation where you're creating hypotension secondary to removing more fluid from the vascular space than is refilling that space from the rest of the body that is also retaining fluids. So if you do get intradialytic hypotension because you're aggressively ultrafiltrating, or you're getting hypotension that's occurring as part of your hemodialysis session, it can definitely contribute to progression or chronic loss of renal function, which is obviously something we are trying to avoid. It's generally accepted that if you use rates of around 5 to 10 mils per kg per hour of ultrafiltration, that can safely be tolerated in dogs, cats, and people. And it's a balance between not removing too much fluid and creating this intradialytic hypotension, but in the same token, you want to be able to relieve the excess fluid burden so that the hypertension and congestive nephropathy, pulmonary edema, and many other organ systems that are affected by volume overload can have some relief. When you're performing ultrafiltration, various complications can occur. I mentioned hypovolemia already. So you're during ultrafiltration, you can see tachycardia or tachypnea, hypoxemia, restlessness, nausea, and vomiting. People complain of cramping when you're getting high ultrafiltration rates. Hyperthermia can be a result. And if you really hemoconcentrate the blood, then you can get increased clotting and poor catheter function. So during a ultrafiltration session, we're going to do a lot of monitoring to try and catch that intradialytic hypotension. And if you're talking about, what is the best way to catch it, when you're talking about just measuring the heart rate, tachycardia would be a late finding that you would already kind of were, way beyond where you'd want to intervene. Same with the blood pressure. If you're already hypotensive, you missed the opportunity to intervene. And you can even see a visible desaturation of the extracorporeal blood that, again, probably isn't highly sensitive, but it can help you monitor for desaturation. So the monitor now, it helps us with two things. One is venous oxygen saturation, and that is something that is proportional to cardiac output. And it is an early and sensitive indicator of, excessive ultrafiltration and possible hypovolemia and hypotension. Also, the monitor can help us monitor changes in blood volume, which is also a sensitive indicator of overaggressive ultrafiltration. And if you trend that with the oxygen saturation, it can be very helpful. It can even help you figure out dry weights in chronic cases. So when you're doing ultrafiltration, even though the water is leaving and going into the waste bag, the red cells and the proteins are not removed. They're staying in the intravascular compartment. So changes in relative concentrations of either red cells or proteins can provide a non-invasive way to assess relative changes in blood volume. And if you serially monitor the hematocrit or hemoglobin, and also the calculated change in blood volume that you can get from serially monitoring those, you can predict adverse effects like hypotension more rapidly than traditional variables and intervene before your patient is in trouble from it. As hematocrit and blood volume are inversely related, the hematocrit can then provide a hematocrit-based estimate of change in blood volume during an ultrafiltration session. And the study did mention a study that was done in baby humans where they looked at the crit line and correlated it with Coulter counter counts of the hematocrit, and there was good correlation. The crit line kind of works through optical technology. There is a little blood cartridge that I'll show you a picture of that the blood percolates through, and then this click device that you see kind of measures the blood as it's going through there. It's transilluminated by multiple wavelengths of light and uses something called Beer's law, which relates light absorbance and its transmittance through any given material to measure a hematocrit. Both the crit line 3 and 4 monitors provide continuous monitoring of the hematocrit and venous oxygen saturation. And then they do a relative blood volume changes calculation by using that calculation you see there. Here's just a picture of the monitor screen, and it's plotting on the y-axis on the top is change in blood volume. The lower portion of the y-axis is an oxygen saturation, and then time is along the x-axis. You can see that it gives you on the bottom right there the venous oxygen saturation. Right above that is the change in blood volume percentage. And then the hematocrit and a calculated hemoglobin are right above that. And then you can see on the top of the screen there, it gives you the initial hematocrit too, so you can kind of see where you started. It also gives you these profiles that you can see in the upper right-hand corner there, and they can help you figure out if you're doing ultrafiltration in a way that you're desiring to. This profile A, which it kind of looks at this upper section of the graph and that curve that's there. You can see in this example, it's a flat curve. There's no slope, downward slope to that at all. And this would be indicative of plasma refill that is occurring at the exact same rates as your ultrafiltration rate. So you're really not doing any meaningful ultrafiltration. And if you wanted to, this may be a situation where you could increase the amount of ultrafiltration you were doing safely without risking intradialytic complication. The other profile that's the exact opposite of the A is the C. And here you can see this steep declining slope. It is indicative of a change in blood volume greater than negative 0.6-0.5% per hour over the last 15 minutes of measurements. It is indicative of plasma refill being at a slower rate than what you're ultrafiltrating. And it's indicative of a rapid decrease in blood volume that puts you at a pretty high risk for intradialytic complication. And if you saw this, you likely would want to stop the ultrafiltration for a period of time to allow that to alleviate. This profile B is in the middle, and it shows you much more gradual slope with less angle than profile C. For ultrafiltration, you would consider it the ideal slope where your rate of ultrafiltration and refill are similar. And it is indicative of changes in blood volume percentage that are greater than -3, but less than the 6.5 that puts you into a C profile. Interestingly, plasma refill can be assessed with this crit line too. If you turn the ultrafiltration off, if the slope continues to decline like that graph on the right, there's not plasma refill occurring, and you probably don't have the luxury of more ultrafiltration. Where on the left, you can see after the ultrafiltration was turned off, you start seeing the graph move in an upward slope, and that is indicative of plasma refill, and then means that you might have more fluid that you could take from this individual. Additionally, when you're not doing ultrafiltration, you can see similar changes in the graph as solute removal creates water movement shifts. So on to the study now. The primary objective of the study was to determine the accuracy of the two crit line monitors, the crit line 3 and the crit line 4, to correctly estimate packed cell volume over a clinically applicable range. And it kind of also would then determine if you could accurately if those PCVs accurately reflected changes in blood volume as depicted by the monitor. A secondary objective was to determine the accuracy of targeted ultrafiltration rate when you compared it to delivered using two different dialyzers, and I'll go into those dialyzers in a minute. And the hypothesis was that the crit line will accurately predict canine packed cell volume, and that the Phoenix machine would deliver a targeted UFR plus or minus 2%. This was an ex vivo study where they used donated packed red blood cells that were less than 45 days from the draw date, but still considered unfit to be used for a patient. Those were placed in a 1,000 milliliter graduated pitcher and diluted with zero point 0.9 saline to a volume that was between 400 and 1,000 mils. And that was our simulated dog then. Each hemodialysis session was defined as one continuous 6-hour period of data collection. And they used a MedComp 11.5 French 20 centimeter dialysis catheter. The Gambro Phoenix X36 was the dialysis machine being used. And the two dialyzers were the Revaclear 300 and the Polyflex 6H. Those are those blood cartridges that I had mentioned earlier that the clips onto, and it puts the wavelength of light through. Those attached to the header of the dialyzer. So those two different dialyzers were used at 5 clinically applicable ultrafiltration rates. That's 0, 100, 200, 300, and 400 mils per hour. The machine, I guess, calculates ultrafiltration rate in kilograms per hour. So that was converted to milliliters per hour. Each combination of hemodialyzer and ultrafiltration rate was run in duplicate for a total of 26-hour hemodialysis sessions. And the crit line 3 and 4 blood chambers were inserted in series before the hemodialyzer in the same order each session. I believe these are monitors from the study that they used because they were attached to the article. So they used the same two crit line monitors throughout the study. Both models used the same equation to calculate changes in blood volume. The only real difference between the two monitors is the display. The 4 has, a nicer display, I guess, than the 3 does, and it puts a few more things that you can see and read more easily, but otherwise the modalities are the same. All sessions performed using the same hemodialysis prescription, and you can see they had a circuit size of 75 mils if you didn't include the dialyzers. The pump speed was 100 mils per minute. Dialysate flow was 500 mils per minute. And then they used those bicarbonate, sodium, and calcium settings for the machine. Monitoring was started after subjective equilibration of prime volume, which is very important. If you let the sensor see a mixture of blood and prime, then when it sees only blood, it's going to think that there's been a big change in blood volume when really there wasn't. So the authors assured that there was equilibration time to make sure that that wasn't a factor. Starting at time 0 and for every 15 minutes for the 6 hours, they measured volume of blood in the pitcher, the change in blood volume percentage as depicted by the crit line monitors, the hematocrit percentage as depicted by the crit line monitors, the transmembrane pressure as depicted by the Phoenix. And then at time 0 and every 60 minutes over the 6-hour session, they took a 0.5 ml blood sample to measure PCV. That was a total of 3.5 milliliters of blood, which represented less than 1% of the total volume and was considered an inconsequential with respect to final volume calculations. The PCV was measured in 4 microhematocrit tubes, and the average of the 4 measurements was used, and they also noted whether there was either none, mild, moderate, or severe hemolysis that could be affecting the measurements. Aliquots of 0.9% saline were added hourly to the simulated dog when the ultrafiltration rate was set between 100 to 400 mils per hour. This, I guess, was simulating a refill and allowing for progressive volume change, creating varying PCVs to measure. They also needed to maintain the pitcher volume, simulating refill. It allowed for judicious use of of the packed red cells that were available for the study over a wide range of packed cell volumes, and it avoided air aspiration from the cylinder. All added saline aliquots were factored into the calculations of delivered UFR. The delivered UFR was calculated using this equation where they took the volume current and subtracted the volume 1 hour prior plus the saline aliquot that was added. And then to compare relative blood volume change calculated by the crit line with the actual blood volumes measured in mils, volume measurements were changed to volume change percentage. The manufacturer of the crit line says that in humans, the hematocrits are accurate from 10 to 60% plus or minus 1 standard deviation. And the Phoenix claims an ultrafiltration range. Well, it has an ultrafiltration range from 0 up to 4 kilos per hour with an accuracy of plus or minus 2%. The statistical analysis for this study, they used scatter plots and passing Bablock PB regression to assess corresponding crit line hematocrits and measured PCV data distribution, as well as total bias, essentially. Agreement was assessed using an empirical Bayes method to compute the best linear unbiased prediction, the BLUP, and total bias were calculated by ordinary least squares after substituting the BLUP for the true value. Similar methodology was used to assess accuracy in volume changes. And the association of the degree of hemolysis on the relationship between crit line and PCV, and for the dialyzer on the relationship between delivered and targeted UFR, was assessed using linear mixed models with reported measurements within units. So a total of 140 PCVs were collected, and you can see these graphs show PCV and crit line values on the y-axis, PCV and crit line hematocrit values on the y-axis, graphed against the BLUP of the PCV on the X, and then bias is represented on the y-axis on the right. The red dashed line is the bias, and the solid black line is the BLUP of the PCV, and the dashed line then is the crit line, either the 3 or the 4 there. And what you can see here was when you had very low PCVs, regression lines for the hematocrit were greater than the reference. So at low PCVs, the machine read a little bit higher than reference. And then as the PCV increased, regression lines for the hematocrit were increasingly less than reference. So the higher the PCV, the lower the crit lines measured. This is the bias with its 95% confidence intervals graphed against the BLUP of the PCV and the crit line 3 and 4. And you can see there was less proportional bias in the crit line 4 than 3. Total bias less frequently differed from 0 in the crit line 4 than 3. And when you assess the 95% confident bands, the crit line 3, the hematocrit was significantly different than the reference when PCVs got greater than 25. And for the crit line 4, the hematocrit was significantly different from the reference PCV when it was greater than 30%. These now were results in changes in blood volume. And here you can see the change in blood volume percentage and the calculated blood volume change graphed against the BLUP of the calculated volume change. And again, the bias is on the right side like it was before. So agreement between the the change in blood volume percentage as displayed by the crit line and serial volume measurements. There were deviations of that, the crit line percentage blood volume change from the reference line calculated volume change are increasingly more negative with increasing change in blood volume. So, as it's with the crit line 3, if you had volumes or gains that were less than or greater than 20%, there was significant deviation from the baseline. And with the crit line 4, that was to losses of 20%, but gains up to 60% before it deviated away from the reference. So total bias was significantly different from 0 in crit line 3 at larger changes in blood volume than it was with the crit line 4. As far as results for accuracy of ultrafiltration, across all measurements, the delivered UFR was significantly less than what was targeted. And at an ultrafiltration rate of 0, volume consistently needed to be added to the simulated dog to maintain the volume in the pitcher, suggesting baseline ultrafiltration. The total milliliters per hour difference between delivered UFR and targeted UFR progressively increased as you moved from UFR 100 up to UFR 400. And with the UFR 400, a median volume of about minus 340 mils was removed with a range of 310 to 390. Here are those two dialyzers again and their statistics. You can see the 6H is a bit of a smaller dialyzer than the Revaclear 300 with less surface area there, but they both have pretty large KUFs, which means that their permeability to water is enough to do pretty much any ultrafiltration that would be desired. In the study, it also found that the average proportion of fluid removed progressively increased as you moved up from UFR 100 to 400. And you can see there only about 60% of the delivered UFR was obtained down at 100, but when you got up to 300 and 400, it was closer to 85%. And both dialyzers seem to perform similarly. So in the discussion, to kind of put it in easier terms, the crit line 3 accurately reflected packed cell volumes less than 25%. And it also accurately reflected changes in blood volume percentage when gains or losses were less than 20%. The crit line 4 accurately reflected packed cell volumes when they were less than 30%. And changes in blood volume percentage were accurately reflected when actual volume losses of less than 20% and gains up to 60% occurred. So, in general, the crit line 4 consistently performed better than the crit line 3 with accuracy at a wider range of both packed cell volumes and change in volume. The investigators noted that hemolysis did not appear to influence the crit line readings, although in the manual for the crit line, it does say that hemolysis can affect readings, often by reporting higher values. This study used packed cell volume as a reference measurement. It stated that it was a direct measurement with theoretically less error than hematocrit. When I was thinking about that, I wasn't sure which one was more accurate. I do get that, if maybe if you didn't put enough EDTA or mix it properly, or there was a machine error, but I think that there could probably be errors with packed cell volume as well. From the perspective of cost, though, it's obvious that the packed cell volume was probably a more cost-effective way to do this study than looking at CBCs each time you wanted a hematocrit. The authors did note that the study was not designed to determine the degree of which various levels of hemolysis affect the accuracy of the crit line, and that it should be used with caution in dogs with severe hemolysis, like you might see if you're using it for an IMHA patient. The prime volume, the authors allowed the prime volume to equilibrate before making measurements, which was extremely important because if you don't do that and you let the machine see a mix of prime volume and blood, and then 2 to 3 minutes later start seeing just blood, it's going to think that a big change in blood volume occurred. And this would be a tracing from a dog that I did that on. And you can see that the machine thinks that, the blood volume has changed by negative 18%, which would be extreme, obviously, and that the hematocrit has moved from 33 initially up to 40. But this is because I let the machine see the prime volume, and then it made a mistake. That was not its fault, but mine. The authors believe that the prime volume had minimal effect on initial hematocrit reading and subsequently relative blood volume calculations, since this equilibration was allowed to happen. Similar equilibration periods were also allowed after each saline aliquot, so that those would not affect measurements as well. Concerning sodium, sodium content of the blood and dialysate can affect the crit line monitor. The monitor is verified in humans at a serum sodium of 137 milliequivalents per liter. And in the manual, it does note that you can see a 1% decrease in measured hematocrit for every 12 milliequivalent increase in sodium above that 137. So for the study, the blood was stored in sodium citrate and then diluted with 0.9% saline, which have sodium contents of 165 and 154 milliequivalents per liter. Additionally, the hemodialysis prescription used set the sodium at the lowest possible setting to conserve the resources that they had to make dialysate with the Phoenix machine. Again, the authors theorized that sodium should have fast equilibration, and they didn't think that it was expected to affect crit line readings over a 6-hour span. However, they did note that lower than normal starting sodium concentrations may have contributed bias in the hematocrit readings. Also, large differences in blood and dialysate sodium could also affect delivered ultrafiltration volumes. As sodium moves down that big concentration gradient from the blood to the dialysate, it drags water with it, and you could get much more ultrafiltration than you anticipated. But equilibration was allowed after saline aliquots, and equilibration with dialysis was reached rapidly. So it was thought that these factors were not creating as much bias as they would. If a large sodium differential between the blood and dialysis did cause meaningful fluid shifts, you think you would have seen increased ultrafiltration rates after addition of the saline aliquots. But instead, the data found that the ultrafiltration rate occurred at a constant rate, not at a rate that was more rapid after the aliquots. And additionally, delivered ultrafiltration rate was consistently lower than targeted. And one might have thought that an osmotic fluid drag would have contributed to an increased ultrafiltration rate. So concerning the accuracy of the ultrafiltration rate, using this single Phoenix platform, proportionally targeted and delivered ultrafiltration rate differed by 15 to 40%. And again, like I said before, proportionally less fluid was removed at the lower ultrafiltration rates. Just to give an example of what a big difference this is, instead of removing 600 milliliters from a 10-kilo dog in a 6-hour session, if you were set at UFR 100, you might only remove 360 of those mils instead. In small patients, the margin for error with ultrafiltration is narrow, and it's difficult to balance. If the ultrafiltration rate is too aggressive, again, you get this hemodynamic instability, hypotension, ischemic organ damage, progression of renal injury, and it may lead to a state where we don't have a pet that can eventually be non-dialysis dependent. And if your ultrafiltration rate is too low, you risk resolution of fluid overload and the associated morbidities that go along with that. And again, maybe you have to do more treatments and owners are incurring more costs within the end, may end up also with a pet that can't go forward with treatment any longer. I've personally found the differences in targeted and delivered UFR in this study to be quite surprising. And, so did the authors, I think. And, they did note that this was this single Phoenix machine had undergone standard and scheduled maintenance. And really didn't believe that it was they believed it was unlikely to be a machine error. The manufacturer does give a accuracy of plus or minus 2%, but maybe individual machines could vary, but that seems like it's varying more than you would expect, even if an individual machine varied. And they did note that the data that they collected would really only apply for this machine, and veterinary facilities that are offering hemodialysis, it wouldn't be a bad idea for them to verify the ultrafiltration accuracy of their given machines so that we know what we're getting into with the very small patients, especially. They did also note the ex vivo nature of the study. And perhaps if the study could be done in a similar fashion, but in vivo, where many other forces, including oncotic pressure, vascular permeability, kidney function, the glycocalyx, all of those things would contribute to actual blood volume change, and you wouldn't obviously see those in a beaker. So they did note that the study really cannot be compared to live dogs and that further studies are needed. I kind of wanted to bring up this concept of back filtration because the owners did know the authors did note that human guidelines discourage ultrafiltration rate of 0, and they mainly discourage this because when you're looking at a hemodialyzer, there's always more pressure on the arterial side of the dialyzer than on the venous side. And on the arterial side, that causes forward filtration from blood to dialysate. But when you get down to the venous header, then you can have more pressure in the dialysate side than the blood compartment, and you could see back filtration. And this happens, from the reading I did, this happens on every hemodialysis treatment that you do, and that it's highest with high flux dialyzers, like the ones that were being used for the study, and lowest using low flux membranes when you're doing high ultrafiltration as well. Now, the reason that this could be a concern, of course, is that water can be ultra pure, but it's not, but dialysate itself is not sterile. So the question is, can back filtration lead to pyrogens getting into the blood? And it could, but I think that risk is relatively low if you are using an ultrafilter. But where the real risk, I believe, comes is that, if the authors needed to add up to 45 mils per hour to the UFR of 0 beaker, that would suggest that we would need to give fluids to our smaller patients that are having having a UFR of 0, but being on a Phoenix machine. If this holds true for other Phoenix machines in an in vivo setting, I guess.
Can I interject there? And
Please, yeah.
Whitney, you're on. You can correct me if I'm wrong. If you look at table 1, actually at minimum UFR, 0 UFR, the machine was actually adding fluid to the beaker. It was adding 45 mils. So 0 is not only not ultrafiltering, it's actually adding dialysate to the blood. So it's
I
a gain.
interpreted that wrong.
Yeah,
that's correct. So the machine was adding fluids to our fake patient, not taking them away when it shouldn't.
Yeah, so it consistently under-delivered the ultrafiltration, and if you set it at a minimum UFR, which is supposedly 0, it's actually adding dialysate to the blood. And while this was done exclusively on one of our 2 Phoenix machines, part of the genesis of this study was the fact that we pretty consistently observed that the amount of UFR that the machine said it was doing was not what we were getting in reality when we looked at body weights, accounting for all the fluids that in the prime and the rinse back and everything. We were not achieving the ultrafiltration goals fairly consistently on both machines. So I do think it's a real phenomenon, and I think these machines are really designed for really high UFR rates, and we're often using them at quite low rates, and it under delivers, and particularly important in the small patients.
And I would support certainly my experience with what Larry was saying too, that in many patients that we think are dry and we are not trying to remove any fluid during the course of the treatment, we'll often see that their crit line will drift positive. And that's not necessarily associated with us giving them a recent feeding or giving them water through their E-tube or anything like that. And we've always presumed it was due to just the inaccuracy of the ultrafiltration. And our practice is, well, we will give ultrafiltration so that we can keep the crit line flat, and we'll keep it neutral. And if you don't, it'll often drift up positive +5, +10%, or even more. And I think this is a really nice description of just that can happen from the machine mechanics. Not, we first might want to think, well, what's happening with the patient? Why are they gaining volume somehow? Are they losing red cells? Are they bleeding? But it could just be mechanics of the machine. So I think this is really nice to show that at these rates that are essentially not used in people, the machines are not very accurate. And with the prescribed ultrafiltration that humans will typically have, 2, 5, 7 liters per treatment, if it's off a little bit, plus or minus, then it's probably not a big difference when they're removing such a big volume. But for our patients, we might be just trying to take off 300, 400 mils in a treatment. So if it's off by 100 mils, I mean, that could be a huge amount, whether it's overshooting or undershooting. So the study was really nice to be able to document. I think what we see all the time clinically is just that inaccuracy of the ultrafiltration when we're just trying to prescribe such small volumes of UF to our patients.
Great. Thanks for that, JD. So then the author's conclusions were that despite its limitations, the crit line provides an accurate estimate of canine PCV and blood volume changes within certain ranges. It's definitely a useful tool for monitoring hemodialysis and ultrafiltration in dogs. Clinically important differences exist between targeted and delivered UFR using this ex vivo model, but probably in vivo it sounds like too. Minimum ultrafiltration and lower UFRs appeared to be proportionally less accurate. And, veterinary clinics offering hemodialysis should consider evaluating different machines for difference in targeted and delivered UFR. I think that wouldn't be a bad idea.
And I think that latter bullet point is not, necessarily to repeat the study, but just to continue to look at what does your machine say it's removing and what ends up being the reality of what's removed by looking at pre and post body weights carefully and all of that we try to do.
Well, thanks everybody. I really appreciate you showing up and giving me your comments.
Thanks. I thought that was great. I thought the intro was really, really good information across the board. Thank you.
Thank you.
And I haven't looked at the other machines, but certainly at the Phoenix, in the manual, if you read it, they do give the accuracy of UF. And I think a dialysate flow rate of 500 mils a minute, it says it is accurate plus or minus 50 mils per hour. So, it's essentially saying that it could take an extra 50 or it can give 50 to the patient. And so I've always used that straight from the manual as a guide to say, well, machine's not super accurate. And if we say 0 UF, it might actually give our patients fluids. Let's monitor with the crit line. And, and for us, the crit line is it's a non-optional part of the circuit. The 3 mils that it takes to fill it is worth all the monitoring information that you get. So we always have it on. And so I can't comment on other machines. I haven't looked at the Fresenius 2008 machines manual to see if it might disclose similar accuracy. But that is something you certainly want to look for because you might already have some of that information. I think how that relates clinically is we just need to be aware of potentially undershooting and overshooting your UF goals, even when your UF goal is 0, or even when it's a set number of mils that you need to be aware. And, we all have those patients that we took off 600 mils during treatment. Fantastic. And we weighed them afterwards and they're only 300 mils less. And it's annoying, but it's probably not just the weight of an extra layer or 2 of the bandage. It probably reflects more of the ultrafiltration performance overall. So I thought it was a really nice study to just demonstrate some of the machine's contributions to what we see clinically with these patients, maybe coming off a bit too dry, a bit too wet from their treatments. And I think the crit line does help minimize those changes being clinically significant. If you see your patient drying out too quick, then you stop your ultrafiltration, you watch them. If the crit line doesn't become negative enough, then you crank up the UF rate so that they do become negative. So I think that's that's what we see clinically and how we use it. But this is just a really nice way to take the patient out of it. And even though it didn't factor for those patient interactions in the contribution, it really just shows, what the machine can do and how it can mess with it, which was really nice to see. So I thought it was a really nice paper and just makes us understand a bit more how we use that as a tool to help monitor our patients. So nice work.
All right, well, I guess we'll call it a session. Great paper, Whitney. Thanks for writing it.
Thanks, Seth. Good job on Journal Club today.
All right, thanks, everybody. Have a good day.